PROMISE MG, how did we get here? So what does PROMISE MG stands for? It stands for Prospective, Multicenter, Comparative Effectiveness Trial of Immunosuppressive Agents for Myasthenia Gravis. Quite a mouthful, that is. So let me tell you a little bit about this. And we're going to take a step back here. My previous speakers are a hard act to beat, but this is a little bit different. They spoke about upcoming treatments, other advances, looking at different areas of the receptor and different mechanisms to attack. What we're doing in this trial is really looking at taking a good look at agents that are already available. As many of you may know or may have experienced, the choice of an agent in myasthenia gravis, an immunosuppressant agent, is not easy. There's a lot of things that go into that choice, including your preferences. What is it that you want from treatment of the disease? What kind of side effects do you want not to have? And what would you be willing to tolerate? And where do you want those treatments to take you? What is a good outcome of the disease on you? And that's really what this trial focuses on. So how did this happen? As Nancy mentioned, a group of us, Don Sanders, who is the co-PI of this PROMISE MG trial, Gil Wolf, and a group of others, international and national experts in myasthenia gravis, had just finished developing the consensus guidance, which was very graciously supported by the MGFA. It's available on the MGFA website for those of you who may not have seen it. It's also open access, again, generously because of the MGFA's contributions. And I was at a PCORI meeting. At this time, this had just been submitted. I was actually representing the American Academy of Neurology. And it's sort of interesting how if I'm out of the actual clinic area, usually in the bathroom or trying to do homework with my son, that's when some interesting ideas come to me. So I'm just sitting over there and listening to all this, and I'm thinking, okay, you know, when we did the consensus guidance, we had to bring together 15 people. Well, I didn't count because I was really sort of the methodologist for the project. But we had to bring all of these diverse opinions together and get some consensus regarding treatments to inform clinicians as well as patients. And when we did that, it was not just the consensus part that stood out for me, it was how diverse those opinions were. And so why are opinions so diverse? Well, because we don't have a large number of high quality, huge randomized controlled trials for many of the treatments that we typically use in myasthenia gravis. The thymectomy trial that Dr. Howard alluded to and his eculizumab trial were not yet out at that time. And when we don't have a large number of trials, then each of us takes our own experience, our own sort of teaching experience, all of that into account to treat patients. Now, why is it that we don't have so many randomized controlled trials that are high quality? Again, Dr. Howard alluded to a lot of this. Because when we do a randomized controlled trial, for various epidemiological and study designed reasons, we end up getting a small group of very homogeneous patients. They all have to be between 18 and 40 years old. They all have to have acetylcholine receptor antibodies. They all shouldn't have hypertension, diabetes, anything else. So, and that's a good thing because we get very robust results. The problem is no two patients with myasthenia act the same. Treatments for myasthenia take a long time to take effect sometimes. So we would have to do these trials for 2 years, which we cannot afford to do. So there is lots of reasons. So I'm thinking, why don't we think out of the box on this one? And why should, let's see, there it is. Why should we not look at real-world clinical practice? Who does well and who doesn't do well? And what are the factors that make them do well and not do as well? And so the other problem is, if you look at all of these groups of medications, azathioprine, mycophenolate, cyclosporin, methotrexate, you have trials that compare them with placebo. But you don't have trials that compare them with each other to see, is there one that works better in some patients? Is there one that works better, period? Is there one that has less side effects, period? We don't know. We know their absolute side effects, but we don't know sort of a comparative approach to any of these medications. So I said, let's do an observational comparative effectiveness trial. So I go to the PCORI website and I say, wow, their next letter of intent is due in May. It gives us 3 months. And the PCORI letter of intent is like a mini grant. Some organizations just want you to say, hey, listen, we're just giving you the heads up, we're going to apply. But PCORI actually wants it like a mini grant proposal. So that's not too much time. So I hurry up and email Don Sanders, and Don says, let's go for it. Okay. So what is PCORI? We're going to go for it, we better know what the organization is. PCORI stands for Patient-Centered Outcomes Research Institute. How many of you are familiar with this organization? A few of you, okay. So it's an independent, non-profit, non-governmental organization in Washington, D.C., which was established by Congress, mandated by the Patient Protection and Affordable Care Act, also known as Obamacare. It was authorized, it really talks about research done differently. And what does that mean? PCORI funds research that can help patients and those who care for them make better informed choices about the healthcare decisions they face every day. And how are those choices guided? Those choices are guided by the very people to whom those decisions matter. So by patients, by stakeholders. And what do we mean by stakeholders? Patients are a big stakeholder because you are the ones who face the disease and the side effects of the disease. You are the one you are the ones to tell us what you want from your treatments. But also payers, advocacy organizations like the Myasthenia Gravis Foundation of America. All of these are stakeholder partners in anything that we do. So how is PCORI funded? It's funded by something called the Patient-Centered Outcomes Research Trust, or the PCOR Fund, that was also established through the Affordable Care Act. 80% of the funds received by the trust are given to PCORI. And I'm not going to go through, because we are running a little late, I'm not going to go through the sources of all of this funding. The other 20% goes to the Department of Health and Human Services, mostly to the Agency for Healthcare Research and Quality. PCORI has received $150 million per year since 2013 as part of this funding. Some of you may know that PCORI sunsets in 2019 September. So, for instance, many proposals that have been funded, including our own proposal, go further than that. Ours ends in 2020. But PCORI has set aside funds for all of the trials that they are funding to manage and make sure that they actually complete the trials. And probably what's going to happen, nobody really knows what's going to happen to PCORI after September 2019, and I'm sure electoral politics is probably going to play a large role in what happens. And as I said, PCORI funds patient-centered outcomes research, which is research that helps people and their caregivers communicate and make informed healthcare decisions, allowing their voices to be heard in assessing the value of healthcare options that they have. So it's really about you and what you want. And comparative effectiveness, as I said, basically means you compare two options. It's not placebo. Placebo is not an option. You compare two treatments, you compare two diagnostic tests, or you compare two approaches. For instance, in a clinic, maybe you have a nurse, one approach is you have a nurse calling a patient every day or every week to make sure that they're taking medications. In another, the patients have to keep a diary. So those are two approaches to care. So any of these is comparative effectiveness research. So back to our proposal. So we had to write this letter of intent. So in the two big parts of the letter of intent for PCORI are demonstration of patient engagement. How are we pulling you in to our trial? How are we getting your opinion and input? And the outcome measure should be patient-centered. So Dr. Howard mentioned outcome measures. So what is an outcome measure? In a clinical trial, an outcome measure refers to ways of measuring the effects of a treatment on a disease. So that's the really very, very important part in designing the trial, right? Because you can give people treatments, but if you have no way of measuring it really nicely, you don't know what that treatment did, especially if you're comparing two groups. So those are ways that you measure treatments. It may be a physician examination, so you come back for visits, and I'm sure many of you must have participated in trials where you come back and your clinician will examine you, or you get laboratory work, or in some of the studies, not typically for myasthenia, but in some of the studies, they may do an MRI scan or a CT scan to see what happened maybe to a tumor or to whatever it is that you're looking at. So look at the anatomy of the problem. So all of those are outcome measures. So what is a patient-reported outcome measure? A measure that is directly obtained from you without interpretation by clinicians or caregivers. And they may be self-reported, which means you may just use a questionnaire and tick off your answers, or somebody else. I may sit in the clinic and ask you your answers and tick it off, but I shouldn't interpret your answers for you. It should be exactly what you say that I put on the questionnaire. And patient-reported outcomes are incredibly important because they get to outcomes that we cannot measure as clinicians. It's only you who can tell us how your activities of daily living are. It's only you who can tell us what your quality of life is. Nothing that we use can measure that other than your own report. There are different scales, as Dr. Howard mentioned, or instruments that measure these outcomes, and they may be disease-specific. So just for myasthenia gravis, your MG-ADL, which he mentioned, MG-QOL, are disease-specific scales. Some of you may have heard of the short form 36, which is used in many trials. That's a general scale, looks at physical functioning, emotional functioning, and you can use it for sort of any diseases. I'm not going to go into details of which one's better, or there are pluses and minuses to both of them. So this is I don't know how well this projects, but this is really the MGQOL 15. Again, Dr. Howard was mentioning 15 questions, each of them scored on a 0 to 2 scale. So your score ranges from anywhere from 0 to 30, and the higher scores are worse scores. Similarly, and this is patient-reported. The MG-ADL is also patient-reported. You have 8 questions. 0 to 3, so your total is 0 to 24. Higher scores are worse. So back again to our letter of intent. The second issue was engagement. So in order to get as much patient input as possible, we went through a lot of steps. The first one was to get Ms. Kathy Bibeau. She's, I don't know if she's here. Hi. And she's been great in giving us a perspective of the patient. So she is the Seattle area MG support group leader. And so we've gotten input from her from the stage of the letter of intent, and she still remains on the leadership of this study. Payer engagement, so this is insurers. Dr. Andrew Kruger, who's the medical director of an organization that provides care for chronic care management services. And then from the Myasthenia Gravis Foundation of America, we have Dr. Jürgen Winitz. He's a patient. He's also a scientist. He's a professor of clinical pharmacology at Virginia Commonwealth University. And he's an MGFA medical and scientific advisory board member. Other stakeholders we have are the Myasthenia Gravis Association of New England, and some physician advocacy or physician organizations, the American Association of Neuromuscular and Electrodiagnostic Medicine, and the American Academy of Neurology. So having sort of found our stakeholders, we said, let's develop this patient-centered outcome measure. So do we need one? We have a few, the MGQOL, MG-ADL. Do we need a new one? Well, let's go ask our patients. So in May 2016, at the MGFA meeting, Dr. Guptill, who's one of our co-investigators at Duke, surveyed 58 people with self-identified myasthenia gravis. We came up with this 22-question survey. It took only just about 5 minutes to do, and the survey responses were recorded. Basically, we were looking at two major issues. How do your MG symptoms impact you, and how do MG treatments impact you? So what is it that you want from your MG symptoms? How much do you want them to go away? Which symptoms are really important to you that you want them to go away? Which can be mild and you don't care very much about? And same thing about the treatments. What are the treatment side effects that are the worst for you? So in the survey, patients responded, interestingly, that staying out of the hospital was the most important outcome for them. We do not want to go, and I can hear the agreement here. Living independently, walking normally, and normal speech, grooming ability. So this sort of being independently able to live appeared to be really big for patients. Single symptoms such as avoiding ptosis were less important. Treatment-related issues that were rated as very important included fewer or less frequent side effects, fewer pills or less frequent dosing, and maybe being able to see my physician less frequently. So basically being able to carry on as normal a life as possible. We then did step 2. So we took the results of this patient survey and we developed a script for a focus group, and that was very generously supported by MGFA. This was an online focus group. We identified 13 patients with myasthenia gravis from the MGFA registry at the University of Alabama. They had to be able to use a computer, have internet access, and we had a moderator from this group called MindSpot that ran the focus group for us, and we sat in as well, so we could hear in real time what patients were saying, and we could also say if something interesting came up that we wanted to pursue a little bit and get a little bit more information, we could do that as well, because we could indicate to the moderator. So what did we do? We showed them currently used outcome measures. We told them what an outcome measure means, showed them the outcome measures that we use, and said we are trying to develop a good patient-centered outcome measure. We want to see what your thoughts are. Same scenario in terms of treatments and in terms of the symptoms of the disease itself. So the question was, what words or images do you associate with myasthenia gravis? And most patients said it's frustrating because people don't understand how sick we can be. We don't look so sick so often, it's frustrating. And this picture shows what words came up most. So the bigger the word is, the more frequently it came up. So fatigue, double vision, weakness, and frustration were the words that were the themes that came out of this question. What words or images do you associate with myasthenia gravis? Again, you see the same themes: vision, fatigue, and breathing. So those were the big ones, again, that patients were concerned about. Based on these two sort of surveys of patients, the online focus group as well as the patient survey, we sort of went through and looked at our outcome measures. Now, those measures have been developed very rigorously and they have been tested for validity several times. So do we want to reinvent the wheel and go develop another one, or can we use them? And when we looked at this, we said, you know, the MGQL15 probably captures the essence of most patients' concerns about the disease and treatments. So we did one last step. At the Duke Myasthenia Gravis Clinic, we administered this, the MGQL15 to 30 people with myasthenia gravis. And we asked them how completely and how accurately. So two different themes. Does it completely describe your experiences with myasthenia gravis? Does it accurately describe your experiences with myasthenia gravis? And we said, if more than 75% of the people we survey say that it seems okay, then we're going to take it. Otherwise, we'll sort of see what we have to do. And we said that before we had the response of the survey. So this was a priori. We said 75% of the people we survey have to say it's okay. And they did. 29 out of the 30 people said either very or somewhat completely to both the content and the accuracy questions. So this is the conceptual model for our study, and I'm going to walk you through it. We have myasthenia gravis. We have lots of treatments. We have the medication, symptomatic, immunosuppressant. We have thymectomy. We have IVIG and plasma exchange. All of these treatments are influenced by several factors. You have patient factors. So this is just the age of the patient, childbearing potential, other diseases, hypertension, diabetes, whatever it is, patient factors that influence treatments. We have clinician factors. Some of us may be more comfortable using some medications. Some of us may have more experience using some medications. We have patient preferences, your preference. Some of you would say, I just do not want to take steroids, no matter what. Some of you would say, well, it's really important for me to get my disease controlled quickly, so I'll take whatever it is that you give me. Some of you would say, weight gain would be a no-no for me. That's not a side effect I want to have. And Dr. Howard touched on these factors as well. So those factors, all of these are going to influence the treatment you receive. And that, in turn, is going to influence your outcome. The outcome is going to be disease remission, symptom control, and adverse effects of medications. As he said, there's no medication without adverse effects, and that in turn will influence health-related quality of life. So that was sort of a conceptual model to describe what happens with patients. So what are our objectives? The first objective is to compare the effectiveness of azathioprine versus mycophenolate. Commonly used medications, we still don't know how they compare to each other. And we'll do that at 2 years of treatment because these medications, azathioprine especially, can take a while to kick in. The second is an interesting one. So some of you may have had the experience that you were started on a medication, didn't do very well, went to somebody else who looked at you and said, well, you just needed a higher dose for a longer time with the same medication. You weren't treated with the right dose. And it's the same medication. So we want to see how outcomes will differ between patients who are treated with what we think are adequate doses for an adequate period of time versus not being treated that way. So very quickly through the inclusion criteria, we are looking at adult myasthenics because we needed a certain number to be able to determine effect, and it would be difficult to do with children and adults mixed into the pool. And they have to have acquired autoimmune myasthenia gravis with weakness, as Dr. Howard said, clinically, you have to have weakness, confirmed by more of the testing that he mentioned. Patients can be on pyridostigmine if they've been on it for 3 months or less, but not more than that. And they cannot have been on steroids either previously or at the time of their visit, or on immunosuppressant medications either previously or at the time of their visit. And that's in order to get a pool of patients in whom our measurement of the disease treatment outcomes is not going to be influenced by previous treatments. We will not include non-autoimmune myasthenia. And as I said, patients cannot be on immunosuppressive agents either at the baseline visit or have received it at any other time in the past. Patients who have received steroids for a brief period of time for something else, say for asthma attack, more than 3 months ago for 10 days, that's fine. So we have some qualifying criteria for the steroids. What are we going to do? We have 20 centers, at least some of our co-investigators are in the room here today. And these patients will be enrolled after obtaining informed consent, but they will not be treated any differently than they would have been if they hadn't enrolled. They will receive medications exactly the way their physician would have treated them otherwise. So it's real-world observational. We just treat you like we would otherwise, and we see what happens to you at 2 years. And so unlike a randomized controlled trial, the statistics for this have to be very carefully done. So we have some fancy statistics to adjust for multiple things in the real-world situation. Similarly, there are no fixed study visits. You just come in for your study visit, for your regular clinical visit, as determined by your clinician. You have testing, monitoring for laboratories, monitoring laboratories, whatever it is, as determined by your clinician. These are the centers. I'm sorry, it's a small slide. I tried to fit 20 centers and the investigators on it. So we have two primary outcome measures. The first is a patient-reported outcome, and that's our MGQOL-15, and I told you how we chose it. The second is a clinical outcome or clinician-reported outcome measure, which is how many people achieve MGFA post-intervention status minimal manifestation or better. So that is when we examine you, we may detect mild weakness, but that's not affecting you functionally. So functionally you're doing fine. We may detect, say, maybe mild eye closure weakness that doesn't matter to you. In addition to that, we are trying to get at the side effects piece, which means we look at what the adverse events are at 2 years. So if you have mild adverse events that don't need any intervention, then we are okay with that. That's a good outcome for us. If it's anything more, if we are stopping medications, if we are adding treatments, that's not a good outcome for us from the standpoint of side effects. So, and then we have several secondary outcomes. MG-ADL is one of them. Dr. Sanders and I will be responsible for the day-to-day administration of the study. We have a great group of people with us to help us on the steering committee, including Dr. Jürgen Venitz, Dr. Jeffrey Guptill, who I mentioned and who many of you may know, Ms. Bibo, and Dr. Kruger. We also have a study advisory committee in addition to the steering committee, which will help the steering committee, and that includes the study statistician, the study epidemiologist, in addition to all of these members. I'd like to acknowledge our co-investigators, the Duke Clinical Research Institute, and a very special thank you to the Myasthenia Gravis Foundation of America for having supported this study from the very inception all the way through now. And without the MGFA, I don't think this study would have gotten off the ground. Thank you.